next speaker is Dr. Pratima Mittal ma'am, and she's going to talk on one of the very important topic and which has shown such a good positive results. That's about kangaroo mother care. Dr. Pratima Mittal ma'am is an head of the department, Vardhaman Mahavir Medical College and Safdarjung Hospital. At present, madam is in ESI Hospital. And who doesn't know her? She was a past president of AOGD, past president of...
That's okay. Anjilla, please let me... They have
No. She requires a formal everything, FRCOG and everything. Please, ma'am.
Yeah, ma'am was given fellowship
I'm not
of Royal College as editor, which is for her exemplary work in the field of obs and gynae. Madam has started with the Department of Critical Care, Obs and Gynae in Safdarjung Hospital. And now she has become a role model for everyone. You know, anything in critical care, if somebody wants to set up, then only one name comes in, which is Dr. Pratima Mittal, ma'am. Oh. Ma'am, now the floor is all yours. And we are here to learn something again, very interesting from you. It's about
Thank you, Anjilla. I think you are, really exaggerated everything. But thank you very much
for
the nice words. And Madam Dr. Sharda Jain, thank you very much for, inviting me and, giving me an opportunity to share our experience with everybody. I'm not able to share the screen, so I don't know if we are... Deepika, will you be playing the slides now? Okay. So today I'm going to talk about Kangaroo Mother Care. In short, we say it KMC, and why now we are focusing on immediate Kangaroo Mother Care, and we have done a project on this. So I'll be talking about that. But before that, I would just like to highlight, next please, that every year there are about 20 million infants which are born low birth weight, and 95% are in the low or middle income countries. And if you look at these, these infants are also at increased risk of early growth retardation and early developmental delays. And of course, the neonatal deaths, 70 to 80% neonatal deaths are due to low birth weight. Next, please. So what is, the current WHO recommendation regarding Kangaroo Mother Care? Kangaroo Mother Care is recommended in health facilities for routine care of newborn babies weighing 2,000 grams or less of birth, and brief sessions of KMC should be initiated when the baby is stable and baby begins to stable, and it should be continuous KMC as far as possible, which should be provided to clinically stable babies. See, at the moment, the current WHO recommendations are to provide KMC to the clinically stable babies. And now, of course, they are in the process of changing these recommendations, but I would like to highlight why we need KMC. Next, please. Because KMC Cochrane review, which was done in 2016, clearly shows that 40% of reduction in neonatal mortality was seen because of the KMC. There was 65% reduction in sepsis, 58% reduction in hospital readmission, 72% reduction in hypothermia, 88% reduction in the hypoglycemia. So all advantages are there because of the KMC, because the skin-to-skin contact with the baby, and that is why it is advocated by WHO universally to all the preterm or low birth weight babies who are stable. Next, please. So what is KMC? The care of preterm or low birth weight baby, where the mother keeps the baby in skin-to-skin contact on her chest continuously, or until the baby no longer wants to stay there in that position, and she exclusively breastfeeds the baby. So two things are important, the skin-to-skin contact and exclusive breastfeeding. Next. So what are the benefits? KMC reduces mortality. KMC facilitates physiological stability of the baby, better thermoregulation, facilitates the early initiation of breastfeeding, reduces risk of nosocomial infection, reduces the risk of apneic attacks, which I have even the Cochrane review very clearly has shown. Next, please. And to the mother, it promotes the bonding between the mother and the baby. mother is less stressed. We have seen that the mother is really less stressed during KMC, as the mother is more actively involved in the care of the baby, and of course it is economical to the family. Next, please. Okay, so what is the procedure of KMC? Well, we have to prepare the mother and the family for the KMC, counsel them about the positive attitude, and should be provided with the special KMC garments. If the special garments are not there, even the open gown, which is the gown which is open in front, is good enough. And the kangaroo position should be explained to her. The baby should be placed between the mother's breast in an upright position, and the baby's head should be turned to one side. Hip should be flexed, and abduction in frog position should be there, and the arm should also be flexed. I will be showing you this position later on. And baby's abdomen should be at the level of the mother's epigastrium. And of course, mother should be explained how to feed the baby, how to breastfeed the baby. Next. So we were doing this, this was being provided to the stable babies. Then it was realized that the studies included in the Cochrane mortality review showed very clearly that the mean age of randomization of the baby to the KMC is 3 days. And about half of the preterm deaths occurred in the first 24 hours and over 3/4 in the first weeks. And the majority of the preterm births occurs before KMC can be initiated, because as per current guidelines, the baby has to be stable before you start, KMC. So what does it mean? That what should be done? The research question came: does continuous KMC initiated immediately after birth, compared with the current guidelines, will improve the neonatal survival? And for this, next please. Next. So these 2 studies in the Vietnam also were done on this, and they said the 2 small studies, and they said that it is safe and helps in low birth babies if the stabilize, and it helps them to stabilize faster if it is done immediately after birth. Next please. Even in the unstable baby. So this study was designed, a randomized controlled trial was designed in the hospital. It was a multi-country study, multi-center study. Next please. Next please. In this, 2 groups were made, intervention group and control group. The intervention group was mainly where the KMC was started immediately after birth, even if the baby was not stable. Only the babies, next please, the babies who were not, needing any intubation, they were taken into consideration into the KMC studies. And if you look at the, preterm babies or low birth weight babies, mostly 70% of these babies do not require intubation. Mostly it is the, supportive care which is required for these babies, and the control of hypothermia which is required. So the babies' mothers who were unable to provide, KMC within 3 days, or they were not able to, they were triplets, or the babies did not need intubation. Those were only babies which were excluded. But otherwise, all the babies between 1 to 1.8 kg were included in the study. Next, please. So 3 components of this intervention was there: continuous skin-to-skin contact with the mother or surrogate starting within 2 hours of birth. See here, it is very clearly that it was started within 2 hours of birth, and with the aim of more than 20 hours per day. And counseling and support for exclusive breastfeeding was given, and of course, provision of a required medical care for the mother and baby in a skin-to-skin contact without separation as much as possible. So continuous care, continuous skin-to-skin care either with the mother or with the surrogate within 2 hours was started in these cases. Next, please. So, and the operationalization was done in such a way that skin to skin at birth, as soon as the baby was born, put on the birth. If the baby does not need any, baby is crying or baby does not need any, respiratory support. So even CPAP babies with CPAP were also taken into the study, and they can also be given this immediate KMC. The babies were provided immediate KMC. They were transported from the labor room or from the operation theatre to the KMC ward in the KMC position, and they were transferred to the mother and neonatal intensive care unit, which was there. The mother was there all the time with the baby in the mother in NICU, that is the MNICU, which was created for this. And then when the babies are better off and they are stable, then in those cases the baby was shifted to the KMC ward, and from KMC ward they were discharged as per the discharge criteria. Next, please. So this is the baby. This is the picture showing that how the baby was placed on the mother's abdomen immediately after birth. Next. This is the baby, how the mother and the baby, and in both of them together were transported from the labor room to the MNICU ward. Next. And from the labor room to MNICU, even with the CPAP also, we could transport these babies from the labor room or OT to the MNICU, either with the mother or with the surrogate. Next, please. So this is the MNICU ward, that is a mother in NICU ward, which is established at the Safdarjung Hospital. And I will just at the end I will just tell you that how you can also make certain few modifications in your system and can make such type of arrangement in your own institution also. Next, please. So this is one unit, which was established in the mother NICU ward, which this unit has a warmer, radiant warmer. It has a monitor for the baby. It has a CPAP machine which can be attached to the baby whenever it is required. It has got a provision of intravenous fluids. It has a provision of oxygen, and of course an adult bed with an adjustable back support. So it is, if you look at your PNC ward, if you there where the mothers are kept. So in those cases, if you make a little extra arrangement for the baby, I think you can have a dedicated MNICU or MNICU type of arrangement in your hospital also. Next, please. So this ward generally should have an infrastructure for the care of mother also. So there is an examination table for the mother, which is there. Pantry is there for the mother to have, mother or the surrogate to have, food, and of course toilet and bathing facilities for the mother or the surrogate. Next, please. So the next, please. This is not required here. Next, please. So in these cases, when we see the baseline characteristics of the intervention and the control group, all were, they matched in the birth weight, mainly being between 1.3 kg, and they matched in the gestational age of about 32 weeks. Next, please. And initiation and duration of skin-to-skin contacts of the infants with mothers and surrogates in the intervention groups was much higher in those cases. It was very high, and initiation was within 1-2 hours. Was in most of the cases it was done in the intervention group. It was possible and it could be done easily, and this duration also was as high as 16 to 18 hours in the intervention group. Next, please. So next, please. Next, please. So if you look at the outcome, then incidence of neonatal deaths, much lower. It was 25% reduction in the neonatal mortality in the intervention group, which led to us to, they said that you can stop these studies because the babies who are not being given the immediate IKMC are at the disadvantage. So that is a very, very important outcome which came out of this study. Similarly, the incidence of hypothermia was also much lower in the intervention group. The incidence of sepsis was also much lower in the intervention group, and of course the mean score for maternal satisfaction was very high in the intervention group. Next, please. And the breastfeeding, additional indicators like breastfeeding indicators, initiation of breast milk, breastfeeding, and continuation of breastfeeding, all these parameters were very, 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 highly appreciated in the intervention group. Next, please. Next, please. So, what was the there were a few concerns also that the how to create a mother's bed in the NICU, how to control infection among the healthcare provider and hospital administration regarding the mother in the mother staying with the baby, obstetrician, how will they take care of the baby mothers if required, and what will be the maybe the mothers, the healthcare providers will be more answerable for certain things because they are being looked upon by every time about the care of the baby and all those things. So these were the concern, but I think they were very, very minor concern. Next, please. Next, and with a little reorganization with the Department of Obstetrics and Pediatrics, the issues could be managed. Even the initiation, there was a challenge regarding the initiation of the camps in the labor room itself, transportation itself, creating an MNICU facility, optimizing respiratory support. All these challenges were there in the operationalization of the IKMC. But with the coordination of the both the teams, it could be handled easily. And I tell you, if there is a will, there is a way. And if we can see the results, so successful results, I think there is no point that that such a small effort should not be made. Next, please. Next, please. Next, please. So this is the way the babies were, transported from labor room to the mother NICU. You can see the baby, even the baby with the CPAP could also be transferred in such a position because only the thing required was the little training to the healthcare worker how to carry the CPAP with the baby and how to handle the mother and the baby in while transporting. Next, please. We have already talked that we were used to maintaining for airway binder was used to maintain the neck and in the extended position. Nasal interface has to be maintained. How to optimize the respiratory support. So you have to look at the position, you have to look at the nasal interface, and you have to look at the proper fixation of these equipment to the mother, to the baby in the KMC position. Next, please. And of course, continuous monitoring. This is a KMC binder which we are showing. This has got two components which we have really got it made in the hospital. This is one is the component, the white component, which is a triangular sort of a binder which is binded around the baby, and the other is the gown which the mother is wearing and which has got a tie, which can be tied at the below so that the baby does not slip. Next, please. So another concern what everybody, even the administration and everybody, was the increased risk of infection. But when we did the systemic review was done, it was saying very clearly shows that there is a reduced nosocomial infection, and in our study also there was a reduced in the risk of infection because the milieu, the bacterial milieu of the mother and the baby are same at the time of birth. And secondly, we did teach all the mother or to the surrogate how to wash hands, and these and before entering into the MNICU they have to wash hands and always keep the all the hygienic practices were allowed to them, were taught to them. Next, please. Other concern was that who will look after the mother, and in those cases the special units were divided. So all the obstetrician used to go and see the mothers, and essential care packages was developed. So if you teach your healthcare worker, even if you are midwives and the healthcare workers about the essential care packages, I think most of the mothers can be taken care of, because the active intervention for the mother is really not required. And even for cesarean babies, we have seen that for cesarean mothers also, we just transferred them even after 2 hours after cesarean to this MNICU, and these mothers can also be taken care of, because these are just only the healthcare workers, the nurses have to be taught how to take care of these mothers, and the package is there so they can really know what to do, and whenever they want to call, they can call the obstetrician. Next, please. So it is this is just showing the couplet care, the medical round by the neonatology team as well as by the obstetrician. Next, please. So what this is a great opportunity. This provides a great opportunity for mother to be the primary caregiver in the MNICU. Here you can see very clearly the mother herself changes the diaper. Mother is even giving a feed to the baby. Even the next, please. So, and the staff and the experience of the mothers was really, really gratifying. All the, mothers were easily able to train in the asepsis routine. They were able to monitor their neonates. They were better prepared for the post-discharge care. Mothers got more support for breastfeeding, and they, expression of breast milk was there much better, in those cases. There was less anxiety and stress in the mothers. They were better parental satisfaction. Positive feedbacks from the patients and the staffs were there. And of course, staff has workload, less workload. Initially the feeling was that staff will have more workload because they will be checked every time. But there was less workload because the mothers were doing half the work, changing the diaper, giving the feed. So everything, it was taken care of. Most of the work was taken care of by the mothers. Next, please. Next, please. So the zero separation of small and sick babies is the goal of our study, was the goal of our study, and it is feasible. Zero separation of small and sick babies is feasible. It is efficacious, and it is safe, and it is acceptable. Next. Next, please. So even in COVID times, after the research was finished, we could continue these practices in our COVID time. All the COVID appropriate behavior was expected, was followed. And of course, the only COVID negative mothers were kept in the MNICU in this doing. And these infrastructure facility, the whole this facility is running successfully even in the COVID time. So, continuation of this facility is feasible. It is not difficult even if it is without research. Now it has come into a routine in our hospital. So all the babies who are 1 to 1.8 kgs, if the space permits, they are permitted. They are admitted in the MNICU. They are taken care in those places, and the results are definitely mortality and satisfaction rate is definitely much better. Next, please. So to conclude, I would just say that immediate KMC for 1 to 1.8 kg infants significantly reduces the risk of neonatal death by 25%. Immediate KMC provided to every baby, every baby, 27 babies serves a life, which translates to 1,50,000 lives globally every year. So we can save so many lives, by this immediate KMC, and it is a paradigm shift in the care of the low birth weight babies. And it should be, all the obstetrician and pediatrician as a team should adopt this in their institution. Next, please. Next, please. So one should scale up their NICU to the MNICU. WHO guidelines are being updated. New NICUs should be designed with all the provisions for mother as a caregiver, as in MNICU. And of course, already functional NICU units can be renovated, and enough of government is ready to provide enough funds for such changes. And of course, we as a healthcare providers, made a NICU first. They take the baby to the nursery. Now we have to bring them together. And definitely if the results are giving such wonderful results we are getting, so we should establish practice of zero separation from birth based on our better understanding of the physiology. Next, please. So our policy should be to permit mother and surrogate in NICU for 24/7 period. MNICU should be there to keep the mother and baby together right from birth with zero separation, and modify your settings so that this is feasible, this is practical, and this can be done. Next, please. Thank you very much. And we should just make sure that mother is a care provider and should not be just a visitor in the NICU. And I would like them to play a small video, 2-minute video is there, which is showing you about our MNICU in the Safdarjung Hospital. And my appeal to all the gynecologists is that please cooperate in establishing these units. You know what is happening, that whenever the pediatrician says that there are responses that we don't have space. So I think that thing should be there. We have to be proactive at that. If we establish, even like we have established, most of the government hospitals are now been asked by the government to establish critical care units. Similarly, in the, the government will be asking all the government hospitals or government facilities to establish MNICU in their facilities. But I would urge all the private practitioners, although corporate hospitals also, that they should establish such units, because the dividends are really going to be very, very rewarding. So I would just like them to play, Geetika, I would just like you to play the video, small 2 minutes video. And then I would like Dr. Chellani to talk about.
Ma'am, the video Dr. Vikram is sharing.
Okay. I will say it was a lovely presentation. We will take Dr. Harish Chellani's comments after this video. Jyotsna, after that you...
Can we have the sound actually?
डॉक्टर अनम्यूट कर लीजिएगा अपने आप को.
नहीं इसकी वीडियो की साउंड.
The immediate KMC study, the mother newborn ICU is one of the sites for multi-center, multi-country immediate kangaroo mother care study. Currently, newborns with birth weight less than 1.8 kg are shifted to newborn ICU and mothers visit NICU intermittently from postnatal wards. For the immediate KMC study, the mother newborn ICU was created so that small and sick neonates and their mothers are cared together 24/7 from birth till discharge to achieve zero separation. As soon as the baby is born, he or she is placed on mother's abdomen. After initial care at birth, baby is put in kangaroo mother care position with mother or surrogate and transferred to MNICU in KMC position, thus providing immediate kangaroo mother care. If required, CPAP is also given in KMC position. Each mother-baby diet cubicle has all provisions for level 2 ICU care of baby. It has radiant warmer, CPAP machine, oxygen, suction facility, vital monitors, phototherapy, and adult bed with adjustable back support for mother. In MNICU, there is hand washing station for mother and healthcare worker, nursing station and counseling area. Apart from this, it has a kitchen, dining area, bathroom and toilet for mother and surrogate to use, and mother's examination room. In mother NICU, mother is the caregiver, changes the diaper, she feeds the baby and continuously monitors the baby, thus providing developmentally supportive care. Here, mother is able to provide prolonged, continuous, effective KMC as long as 17 to 20 hours per day. The babies who require CPAP are also cared in KMC position, and even tube feeding is given while in KMC position. Since these mothers have just delivered, obstetric team cares for mothers in MNICU itself. Thus, in MNICU, couplet care is provided. MNICU empowers mothers to take care of their small and preterm newborns. IKMC study results shows that newborns cared for in MNICU have 25% lesser mortality at 28 days of age and less chances of infection than those cared for in NICU. Thus, MNICU is a facility where mother is a care provider and not a mere visitor.
Fascinating.
Thank you very much. I think Dr. Chellani can now.
Yeah, thank you, Dr. Pratima. Thank you, Dr. Jain, for giving the opportunity. I think, as Madam initially said, wherever there is a will, there is a way, and that is why we were able to do it. And then I think it is a God's nature that 9 months the baby is kept inside, and suddenly when baby is born, you say, no, you get separated actually. Whatever are the reasons actually, but initially, as Dr. Pratima mentioned, all over the globe actually, except few centers in Norway and Sweden, where now this is practiced. So our center was the only center in Asia which did this study for African countries. And I feel there is a intrauterine life, there should be a smooth transition to the extrauterine life, and mother and baby keeping together, making a concept of zero separation. And as Madam has said, it is not only the survival, the infection rates are less, and now the same cohort we are following and looking at the neurodevelopment outcome of these babies. So we are following these babies for another 2.5 years of age, and these babies have been seen that they are neurodevelopmentally better. And we have seen the stress among the mother and the baby. We have quantified, and we have quantified by salivary cortisol level. In fact, that has also been shown to be reduced. And one of the talk actually with the previous and this talk, actually I wanted to connect that if we allow the surrogate in the policy change in the labor room and make the table more friendly with the side, chains, at least mother will be confident to keep the baby onto the chest. As Dr. Jyotsna was saying, it is difficult for the nursing people to be there, but if we have the family member and we have the side railing so that baby doesn't fall, and they are more mother friendly than obstetrician friendly, then I'm sure these babies would be put in the first 1 hour. From there till discharge, I think mother and baby should be closer and 24/7. That's the way forward. And I remember the words of our Dr. M.K. Bhan and Professor V.K. Paul. When they entered and saw this unit, they said this is going to be the future of our newborn units. And WHO is coming out in next month with the revised guidelines that all babies who are below 2,500 grams, whether stable or sick, they have to be onto the mother's chest. So thank you, ma'am. Thank you for the opportunity to be with you all. Thank you.
I think I visited the center and I was thrilled on that particular day. I have no words to describe, how things are. And as Dr. Pratima has said that the first 3 days for a preterm babies are crucial. Majority of the deaths takes place during that particular time. And if you've done it 3 days later, then probably, the whole thing is lost. So that is what things are about. Dr. Bhasker, Dr. Anjilla, you want to say something? Doctor, we would like to have comment from Dr. Deepika Deka. Dr. Deepika Deka.
This is such a mesmerizing talk. And what Dr. Jyotsna has said, the golden first hour, and Madam has said, and Dr. Chellani, where there is a will, there is a way. I think, Madam, आपने भी कुछ और अब एक कहते हैं drill कर दिया. And it's amazing. I don't know how you guys, there must be a will. That's why you were able to have a MNICU in Safdarjung Hospital. It's amazing. It's so beautiful. It's so beautiful, and we should learn from this. We should learn.
Dr. Deka, you want to say something? Madam is not here.
मैं तो सोच रही हूँ डॉक्टर्स को ही बोल देते हैं कैंगरू केयर में रखा करो बच्चे को अपने. ये जो ब्रेस्ट फीडिंग प्रॉब्लम, everything will be sorted out.
Yes. And I think, surrogate, attendant, she will do the great job. She will definitely do the great job.
Madam,
I would like to see how how this dress is and how they tie.
Yeah.
You know, because it's very interesting.
Angela, let me tell you, this is the same dress which is being used in the Sweden's Karolinska Institute, and we are you are now getting it made in Delhi only, and 2 dresses are given to each family, so that one they wear it, and then these dresses the family take it at home also. It cost 500 rupees for 2 dresses. That means 4 components. The 2 inner triangular portion which Dr. Pratima was mentioning, that is to stabilize the neck and the neck of the baby, so that preterm babies, the neck doesn't becomes flexed and doesn't cause apnea. And outer covering is for the providing the privacy, and also so that baby doesn't fall down. In fact, we have made the video and we have made the toolkit also, that how much is going to be the space, what is going to be the costing of this. So in fact, now we are going to do the implementation research of immediate kangaroo mother care, going down to the district level, how in the district level this is going to be the challenges and how you can overcome that. Yeah.
I think, today's CME had been a very eye-opener thing, and our good wishes to do Dr. Chellani, that I'm sure you will continue with this, but my folded request with the folded hands to all gynecologists that this golden 1 hour should be utilized. Yes. Human milk, and in case if you find, the breast milk is not possible, then probably the donor human milk is there. I would like to have a comment about the donor human milk, Dr. Chellani, from you.
In fact, we don't have the bank right now, but definitely the experience which I saw at different places, I have seen at the SMS Medical College, Jaipur. Then I have seen at Lady Harding. I think it is a phenomenal, and we should develop more. And thanks to Dr. Achala, she has, approached, and she is saying that probably we are going to make that center at our own place also. And with that center, and I'm sure because our mothers are, they definitely are keen to give their own milk. That I have seen now, in fact, in our unit, mother newborn unit, we have got the triplets. And good thing is that, the mother's sister is there and she is also lactating. So she is feeding the other baby. So in fact, all 3 babies are receiving either the mother's own milk or the, one of the relatives, of course, after the consent we are giving. So I think there is a great thing. And once the mother and baby are together, there is an increased opportunity for these smaller babies to have early colostrum and breast milk, which one can start.
Dr. Ma'am, how the milk bank of La Femme was made. Even I was not aware of it. One of a very wealthy rich man.
I'll take 1 minute.
I have delivered her, and she went. They didn't tell me. So they went to our neonatologist, and they say that my wife produces so much of milk. Why we are wasting it? One should donate it. And from there, the idea has started. So he says, the problem is the milk bank, the funding and everything. He said, I will fund. So he is the person who funded this bank. Even a mother who has a stillborn baby, even she donated her milk for at least 1 or 2 months to the milk bank. If you look into the stories of milk bank, how the milk comes, it's really one becomes a teary eye. Even the corporate hospitals, they can do it, and there must be. It's for a milk. There is so much of funding. Imagine, I was not aware of it. My own patient funded this bank, but it's we need to keep honestly. And I was told it was your patient. I was not. He says, my wife produces so much of milk. Why it's being wasted? Yeah. And only on this idea, he said, I will fund. You do it. And our neonatologists, they did it.
True.
Sir, I think I thank you everybody for an amazing CME today. Both the speakers had been absolutely wonderful, and the experts had added the cream to everything. So thank you very much. Thank you, Dr. Chellani, Dr.
Thank you, ma'am.
Pratima Mittal, and Dr. Anjilla, Dr. Jyotsna, and over and above Dr. Vikram Reddy. You have been absolutely fantastic. Thank you very much, sir.
I will say
Thank
to
you.
us. I will say thank you to you for making us a part of it. It's an eye opener for us also
Right? It's good
to do something.
And Dr. जैसे ज्योति भास्कर ने किया आपको भी करना है ठीक है
नहीं वो तो हो जाए
ठीक है
if doctor sometimes India is full of so much of good brains, you know. If you take the somebody's suggestions and just try to change yourself, things do work.
So thank you very much.
Thank you, madam. Gave us an opportunity. Thank you.
Thank you all, ma'am. Thank you so much, Sharda Jain, ma'am, for giving us this opportunity.
Thanks.
Thank you.